Maybe we can start all over again if you don't mind. Let me quickly start because I think the live stream didn't start earlier. So I think thank you for joining us today. We are here to talk during Breast Cancer Month on innovations in breast cancer care and why patients and family members should be better informed about it. We have with us Dr. Jayaprakash Madhavan, who's a senior oncologist, radiation and clinical oncologist from KIMS Hospital, Trivandrum, and Dr. Krishnakumar Rathnam, who's a senior consultant and head of Department of Medical Oncology at the Meenakshi Mission Hospital and Research Center in Madurai. For those of you who may have missed it, yesterday we spoke with Dr. Panda and Dr. Sandeep Ganguly on the, some of the challenges and solutions to living well with advanced breast cancer. And we will be doing a session in Hindi later this month on the 28th. So please mark the date at 4 p.m. on Saturday on 28th of October. Quick reminder, Patients Engage is an online platform for patients dealing with chronic diseases and for them to share experiences and learn from each other as well as from healthcare professionals, because the better informed they are, the better choices we will make. And really what we want is that people should feel supported in the journey with cancer. And you can always check out our YouTube channel for stories and lived experiences shared by patients and survivors on topics which typically people are reluctant to talk about, whether it's about relationships, or whether it's about body image issues, whether it's about mental health or fitness as well. And this webinar is being supported by Pfizer. It is for information and awareness purpose only and is not a substitute for medical advice. You can consult your treating physician for guidance based on the information you receive. And the views expressed in this video are of the speakers and may not be endorsed by either Pfizer or Patients Engage. And I'm Aparna Mittal, I'm the host for this session. If you have any questions, please do share them on our streaming platform and we will address them, or you can write to us at editor@patientsengage.com. And for Dr. Jayaprakash, we are kind of repeating it a little bit because I think we had a challenge in going live earlier. So starting again with you, Dr. Krishnakumar, can you talk us through the typical treatment options for breast cancer, and then Dr. Jayaprakash will come to you for the treatment innovations. You're on mute, Dr. Krishnakumar.
Yeah, breast cancer treatment depends on the type of breast cancer on the tumor. There are different types. Infiltrating ductal tumors is the most common type of breast cancer. And once the lady is diagnosed with ductal carcinoma, the next step which the oncologist would prescribe will be to stage the cancer, whether the tumor is localized to the breast or whether it has spread a little larger in the breast or into the axilla, which we call as locally advanced breast tumor, or whether the tumor has spread beyond the breast, which is called as into the other organs, which we call as metastatic breast cancer. So based on the type of breast tumor and based on the stage of this tumor, the treatment will vary, starting from surgery only, or sometimes the surgery with chemotherapy or hormonal therapy. And in tumors which are large enough, they may sometimes be complemented with radiation also. And the tumors which have spread beyond the breast and beyond the regional nodes, which we call as metastatic breast cancer, or the stage 4 breast cancer for common man, it is usually treated with only drugs, which may range from simple hormones to targeted tablets to chemotherapy to targeted therapy or to even immunotherapy. So that is a very big armamentarium, and the selection of the drug depends on the tumor type, the patient's age, the health, and the available resources in the place where the patient is getting treated. So it's not, what I want to say is breast cancer is not a one-size-fits-all treatment. And
Right.
it is sometimes very difficult to compare between the treatments offered to two members very closely known to each other. One lady would have one particular type of breast cancer, and the lady sitting next to her may have a totally different type of treatment for the same stage of breast cancer. It is very different. And if we apply all this, most of these breast cancers in early and locally advanced stages are highly curable.
Right. Thank you. Thank you, Dr. Krishnakumar. Dr. Jayaprakash, thank you for joining us back.
Okay.
If you can talk us through the recent and not so recent treatment innovations that are available for breast cancer care.
Yeah. As Krishnamurthy said, breast cancer is not a single entity. So it's a different entity. So first, the thing is to go for a biopsy and confirm the diagnosis. Then you type the breast cancer. Usually go with the immunohistochemistry to the hormone receptor positive or a HER2 positive or a triple negative and so on. That's a combination of various. Then depends upon the stage, as you mentioned, we are staging investigations being ordered. Then only we decide the treatment for we always discuss with the multidisciplinary tumor board consisting of interventional radiologist, oncologist, radiation oncologist, surgeon, and rehabilitation. All these people will be there. Then we decide which is the best treatment for them and always discuss with them to know what is their expectations, patients,
Right.
that we want. So breast cancer, mostly in our center, more than 50% of the patients are going for breast conserving treatment.
Right.
So, yeah. All the early stages, we always go for a breast conserving treatment if possible. Other stages, only as you mentioned, we go for a neoadjuvant treatment, and mastectomy is not being done routinely in our center. Yeah.
Right. So, so you mentioned that, even in terms of surgery, there are now innovations. So there is breast preservation surgeries and, mastectomy is much rarer than it used to be. If you talk of, I think Dr. Krishnakumar has touched a little bit on the treatment innovations in drug therapy. Are there other treatment innovations, or can you highlight a little bit or explain the differences between, people hear terms like targeted therapy, immunotherapy, etc. What does that mean? And, what should they know about it? And also in terms of radiation therapy for breast cancer, are there treatment innovations?
Okay. The breast cancer treatment has got two components. One is systemic treatment, other option is local treatment.
Right.
In early breast cancer, the local treatment is mainly surgery plus or minus radiation. And at an advanced stage, mainly local treatment is not given, only very because systemic treatment is the mainstay of treatment. Right. So when in the early stages, when you discuss with the local treatment, you have to optimize the sequencing the different treatment, when to give upfront systemic treatment, then reduce the tumor, go with the breast conserving surgery, and then go with the radiation, then continue with the further adjuvant treatment, depends upon the biology of the tumor and stage of the tumor. So it's a continuous process. And after local treatment, also you have to rehabilitate the patient, especially you are going for a less radical surgery nowadays. The lumpectomy, sentinel lymph node biopsy, and avoiding axial dissection. That's also important to get a good cosmetic appearance of the breast, as well as to the reducing the arm edema. So we have to discuss every stage of the treatment and what the best options for each patient. So rehabilitation also start from immediately after surgery, we start the rehabilitation also. Right.
Thank you so much, Dr. Jayaprakash. So, Dr. Krishnakumar, one of the things that people often think of is because you see more survival stories of people with early stage cancers typically, can you kind of again talk us through treatment options for advanced stages a little bit so that people are a bit more reassured of the fact that advanced or metastatic stages also have treatment options. You're on mute again.
So what generally people understand as advanced stage is not, once again, one single entity. As I mentioned to you earlier, depending on the tumor type, histology of the tumor, the advanced stage can further be characterized as, an advanced stage that needs very, very aggressive treatment. Like, for example, HER2 positive patients or triple negative patients. These patients, if left untreated with stronger therapy, will progress very fast. So it's common sense to start treating these patients with targeted therapy along with chemotherapy. Triple negative patients usually are treated with chemotherapy. And once they achieve a reasonable amount of control, some form of maintenance or, maintain the response to therapy, and the patients are taken forward that way. And the most part of the treatment would probably be some drug or the other. But if you take another bigger basket of patients with advanced cancer who we see nowadays, they are the so-called hormone receptor positive patients. These patients, unless and until they have extensive breast cancer disease everywhere causing a lot of symptoms, there are most of the times they are treated with hormones or certain targeted therapies like CDK inhibitors. And these, with just, for the patient, it looks like just simple pills. Sometimes the patient denies that they are given some special treatment because they feel, why is the doctor just giving me a single pill for treating my advanced stage of cancer? But that's how, even if it's an advanced stage, patients will respond to certain hormonal therapies. So that's how hormone treatment is given in those set of patients. So the bottom line for the practicing physician is not just achieving a good response to therapy, but is also what is very important for us is quality of life. So when we are treating patients with advanced cancer, when we knew right on day one that there is no cure, but we are going to comfort the patient and take the patient along, maybe even years into her life, although we called it stage 4, in these kind of situations, quality of life plays an important role, which is as equal to what one doctor would do to select the type of therapy. So that's how advanced stage treatment is given for, breast cancer treatment is treated in advanced stage.
Right. Thank you, Dr. Krishnakumar. Dr. Jayaprakash, I think, you talked a little bit about rehabilitation. Again, what are the changes that you're seeing in rehabilitation over the years, right? So again, it's, for instance, I know that when you talk to some of the older patients, they used to call lymphedema the topic that the dark secret of breast cancer. Nobody talked about it, nobody dealt with it, etc. But now there are other, obviously lymphedema is talked of, and there may be other areas where there is improvement. So if you can talk us through some of the changes that have happened in cancer care as far as rehabilitation is concerned as well.
Yeah. And another thing is regarding the local treatment. Other than surgery, we are going in less radical surgery, the less axillary dissection, and avoiding axillary dissection in early breast cancer. Similarly, even coming to the radiation also, previously we used to do conventionally 5 weeks treatment or 6 weeks treatment. Now we are reducing the dose reducing the duration of treatment, more convenient to 3 weeks or even 6 fractions, like that 5 fractions treatment we are giving to the breast cancer radiation. So it's convenient to the people. And as far as possible, we try to avoid treatment in the axilla, and also the morbidity of the radiation also can be reduced considerably to the other organ at risk for radiation is the heart, lung. So with the newer techniques, with the volumetric arc treatment, image-guided radiotherapy, we can reduce the dose to critical organs, reduce the lung doses, and it has shown that it's improved the results considerably. Similarly, even with the new Even newer particle radiation like proton beam, it's not available freely in India. It's also useful in that situation.
Right,
So that's a very important thing in the radiation part we are coming. And also the rehabilitation, the physiotherapist also comes to play a big role in the management of the movement and the arm movement. It's very important.
Right. So, you touched on a very important point on the radiation changes and not affecting the heart and the lung. So does that, again, to make it clear to the layperson, does that reduce the side effects of radiation? Does it affect the longer term comorbidities that used to come up or long-term side effects that used to happen?
So we are reducing that, considerably reduced nowadays. Previously, they used to get fibrosis, telangiectasia, many things were there. Side effects were very afraid to go for the radiation. Now it is not like that. So in our studies, people who had a breast conservation treatment has got a better quality of life when compared to those who had a mastectomy. That's our finding. Right.
So I think that's again an important point, because often there is this concept that, mastectomy is safer in terms of breast recurrence. So people are, patients and their families also are very concerned, and they often think that mastectomy is a safer option. To both of you, is there any evidence on that, or is that, now, as you said, with breast conservation also you get good quality of life if you can, again, from a patient perspective, highlight what are the differences. So Dr. Krishnakumar, you talked of type and we've talked of targeted therapy. Again, from a layperson or a patient perspective, can you differentiate between, type testing, figuring out the type of breast cancer in terms of hormone receptor positive or negative, as well as mutation testing? Because I think that sometimes gets a little confusing for patients, is what we find.
Once again, without confusing the patient, what I would like to say is they have to understand that breast cancer is not one entity. It can be divided into various types, and the simplest way to divide the breast cancer into its various types are by testing for hormone receptor, HER2 receptor testing, and how fast the breast tumor multiplies, which we normally call as a proliferative index or the Ki67. So this is well available in India in various centers across private to government. And we probably at level 1 are able to decide treatment for 95% or maybe even 100% of patients with this information, which we feel anything beyond this is not going to change the treatment on day 1. But when a patient, especially advanced stage patient, responds to treatment and at some point of time seems to escape from the treatment that has been offered on day 1, this we feel is because the tumor is trying to change its nature, which we can say probably the tumor genotype is changing. So how do we know whether the tumor has changed its genotype and what is this new type which is it's acquiring over time that is causing resistance to treatment? So this can be tested using more sophisticated tests on the tumor tissue, if available, at the time of progression. Sometimes from the tumor DNA, which is there in the blood, the same test can be done. And we try to categorize the patient as to what causes resistance and then decide what treatment has to be given for the patient. So this is basically about the genotyping of the tumor. Apart from this, if someone asks me, are we using the molecular type or the genotype even in early breast cancer on day 1? Yes, there is only one indication where patient has such a low stage, let us say stage 1 breast cancer or a stage 2A breast cancer, where we feel on basic ER/PR and HER2 testing and Ki-67, we find that the patient seems to have a very good tumor type. If we can spare the patient from chemotherapy, we try to go deeper and try to find the genetics within the tumor. And if all the genes are favorable, we help the patient avoid getting chemotherapy. So there are a couple of tests available in India. There are some tests which are sent to US. So this is done on the tumor tissue. So the typing, it's all about typing of the tumor to select in or select out chemotherapy and targeted therapy for the given patient. That's where the tests come in.
That's where the tests come in. Thank you. And I think, again, it's very important to highlight, because we've seen patients often come to us and say, XYZ had this treatment, why am I not getting that treatment? Why is why do I get chemo? That person doesn't get chemo, etc. So I think it's very important to understand that there are multiple factors that affect your treatment decision. And it's important for you as a patient to have that discussion with your treating physician, but and while you can get support from other breast cancer patients, do not expect the same type of treatment as the other patients. So I think it's important to remember that. One of the areas that I think we've touched a little bit on how stage matters, how age matters, but we are also now seeing older people because we are living longer and older people are getting diagnosed with breast cancer. So Dr. Jayaprakash, do we follow different protocols? Do we have a geriatric assessment? Do we have any form of, are the rehabilitation guidelines different for old geriatric patients?
Yeah, geriatric patients, always we assess the geriatric score and will be there. And also another thing is, as the age advances, the chance of getting a indolent cancer is more, that is hormone receptor positive, HER2 negative breast cancer is more. So, and in early breast cancer, if a low risk group, you don't even avoid radiation to the breast, just lumpectomy alone and systemic treatment with the hormones alone is an option in early breast cancer. And older age also, the intensity of chemotherapy also is reduced. Suppose it's a HER2 positive breast cancer also, we are reducing the intensity of chemotherapy, whereas we manage with the more of targeted treatments in that group. Then even 80 plus, and mostly we go with the hormone treatments. Surgery.
Right.
Yeah,
thank you.
Yeah.
And Dr. Krishnakumar, for younger patients, because we also have a large population, which does get fair numbers are among younger patients. So again, what are the considerations that, what should they be discussing with the treating physician in terms of whether it's fertility preservation, whether it's what treatments cause early onset of menopause, and any other side effects of, like osteoporosis, etc. So if you can kind of summarize what patients should be discussing with the treating physician if they're younger patients.
In India, compared to the West, we have a larger group of younger patients, especially the patients in the age group of 20 to 40, 45 years, we have a large chunk. In these patients, cure has to be the goal. Yes, it has to be the goal in older patients also, but it is all the more a reason that cure is the goal, because most of these women are in the reproductive age group, not just reproduction in its sense, but they are very productive for their family. Most of them are working women. There is a huge, econometrics which is involved when a young woman are being treated for any form of cancer.
Right.
So life of the woman, the young woman, is very precious for the child, for the growing child, for the husband, as well as for the home and for financial considerations. So there is no reason a young woman will want to down tailor the treatment, fearing toxicity. In other words, if there is some treatment that has to go in for her, she should be geared enough to get it rather than trying to avoid it. Now, why I'm saying this is because the younger women, and happily so in India, most of our young women are highly educated. They have Dr. Google with them and they read so many things. They come back and say, oh, I'm scared of chemotherapy. I'm scared of targeted therapy. I had a neighbor who never received chemotherapy, and all these points which we discussed, they are not aware of. And then they take to some form of alternate methods to cure themselves and come back to us a year or two later with a very advanced cancer where we are only able to sympathize rather than treat. So the first advice for younger women will be to discuss with the doctor to see and maximize the goal of treatment and to cooperate with the doctor for the right form of treatment, because she is going to be very important for the growing up family.
Right.
The second point is, after cure comes cosmesis. Once again, I would like to put that point. After cure comes cosmesis. There are a lot of women who I, over the last couple of years, have seen default treatment when spoken about mastectomy because they feel their cosmesis is lost. As Dr. Jayaprakash said rightly so, every single surgeon tries to preserve the breast for the woman if given a chance. But there are some times where we are not able to do that and the patient may need to undergo a mastectomy. Hearing this, the patient resorts to all other forms of treatment and sometimes comes back to us with a large fungating mass or a lesion. And once again, we only have to sympathize rather than treat the patient because the golden time is lost. So once again, the young woman has to cooperate with the treating team and put cure over cosmesis. The third point will be about, now let's say she is accepted for cure, she is accepted for a proper surgery, she is accepted for proper chemotherapy. Now the ball is in our court. This is where we start considering the age of the patient. When we have a young 25 or a 28-year-old who has not completed family, we have to think about fertility preservation. Given the chance that this patient is likely to be cured, after about 4 or 5 years, we need this lady to have active childbearing and be a normal woman in the society. Right? So this has been possible and has been accomplished by certain hormonal treatments which are given along with chemotherapy to protect their ovaries. And this has very much become a part of the routine treatment. And they can be reassured that we will be able to do. However, compared to the normal woman, they may have certain fertility issues. But once again, my urge to the young active woman will be put cure over cosmesis, over fertility, and don't default from treatment. Just because you're not going to childbear tomorrow, we don't want you to lose your life. So life comes first. However, there are fertility preservation techniques, so the woman can discuss that out. Last but not the least is going to be, let us say the woman has completed family, but still is sexually active. When we give them hormonal treatment, some amount of sexual dysfunction is expected. And we have enough number of doctors in the gynec arena who know how to give the certain form of local, hormone gels or hormone therapies. And post chemotherapy or post premature ovarian failure, patients may have a lot of hot flushes for which there are certain drugs which are available. And I can assure them that all these are going to be only for a fixed duration of time, maybe a couple of years at max, after which they are going to be normal, like any other woman in the society. So they have to just bite their teeth, go through the grill, get cured, and then come out as a normal woman, because she is going to be very important for the family and more important for the society. So once again, cure over cosmesis, over fertility, over other personal needs. I think this is the ranking the young woman needs to keep very clear before entering the oncologist's office.
Right. It's harsh. I think I would want to let patients who are listening to this or their family members know that it is not easy. I think the side effects can be quite challenging, but you can also connect to other patients who've gone through this. So management of side effects, I think, is an area where it's good to connect with others who've been through this. And as Dr. Krishnakumar said, that it is these are factors to consider, but don't get swayed. Don't think that there are solutions outside which make life. I mean, there are no easy answers to this, right? So you will have to make these difficult choices. But as I said, that there are always other people who've been through it, and even those 2-3 years, I know we've spoken to patients, and it's really difficult and challenging, but you can get through it. So keep that in mind. We've got one question, and I'll ask Dr. Jayaprakash that question. Is, we've talked of stage of the cancer impacting treatment choice, and age of the person impacting. Somebody's asked us, what is the impact of mental health and the person's immunity, whatever that means, affecting the outcome of the treatment?
Yeah, the positive outlook is very important, because immunity is there. It depends upon your mental status and other things. It's a very delicate situation. So always try to keep the morale in a very high state, and always have a discussion with the family members also. Unlike Western countries, many of the decisions are taken by the family members jointly or separately. Even relatives also will involve in the decision making. That's a very important factor. Another thing is regarding the treatment, especially acceptance of treatment is also a very important factor, especially in the functioning. As a group, I have found that teachers are very reluctant to accept a mastectomy. That because they want to go to school and other things. And I know many people, they avoid mastectomy until they retire from the school. It's like that. So it's even in that situations, even advanced stages also, we are forced to go for a breast conservation treatment, or we go for a breast reconstruction after surgery. That is also, but takers are not many for a reconstruction.
Yeah.
Reconstruction is an area which we have to push more.
Right.
Yeah.
So, for any final words from both of you, I know that we are beyond our time, but any final words, Dr. Jayaprakash, for our audience that is listening on this?
The main thing is that if you suspect in something, or they go for a screening, or you suspect, you consult a local physician and a surgeon too, and then go for a proper treatment. You can take your decision, can take by time, but the thing, you have to go for a proper treatment. Don't head for a false people's and other things. How many systems of medicines are there? So that's a very important thing. And second thing is proper treatment, where breast cancer can be cured completely, and if detected early and treated properly. So the mortality from breast cancer is coming down nowadays because of the early detection, proper treatment, and rehabilitation. So survivorship care also very important, because this after chemotherapy, radiation, and there are many side effects can occur. So we have to pick them early and treat with a good supportive care. That's also important.
Right. Thank you. Thank you, Dr. Jayaprakash. Dr. Krishnakumar, your final words?
Yeah. So what I would, apart from what so much we've discussed, but when it comes to treatment of breast cancer, I hope there are a lot of people listening to this. The side effects aren't so bad if they adhere to certain common advices which are given by the oncologist. It is more of a fear of the unknown rather than really going through something that's bad. Because people often come to the person who is struggling with advisors of their own, certain experiences which they have heard, and then they basically psych up the patient, and that's where the patient actually defaults. So basically they have to go through a proper channel, and then I would only tell the patient the best is to submit yourself to your doctor, not your neighbor, not to somebody who you know as a distant acquaintance. Please come to us. We are here to help you to go through the process. This is number one. And number two, we've not spoken about prevention of breast cancer. I would say that in one single word, if you want to talk about prevention of breast cancer, it's all about lifestyle. If you have a very healthy lifestyle, not starting at your 30s and 40s, but the girl child needs to go for a heavy, good, rigorous physical activity filled lifestyle from her younger years, like 3 or 4 years. There is a delay in her attaining her puberty, and those who are able to, control their menstrual cycles in a good way without too much of hormones, these patients are less likely to suffer from breast cancer. Many young women, many active women try to either avoid or delay getting married. If they get married, they do not want to have children. If they have children, they do not want to breastfeed them because it's not their wish, but it is something that's imposed on them because their work style is such that. But we have to remember, we are going against nature. We are going against the ecological system, and the body reacts in certain abnormal ways. So trying to avoid these kind of risk factors, the woman can prevent herself from breast cancer. And that's my prayer, that the incidence of breast cancer should come down for women rather than going behind the breast cancer if somebody is diagnosed with that. And last but not the least is what Dr. Jayaprakash mentioned, is about screening and trying to detect the early breast cancer. And it is done by women who don't have any symptoms. That is very important. I tell them a simple 20-30-40 rule. It's called the 20-30-40. Any woman over the age of 20 years should be taught or can learn self-breast examination, and they can use internet to their best use. They can go and Google at sites. Self-breast examination monthly once by any woman who is 20 years or more. 30 years or more, every woman twice a year is advised to have a breast examined by another doctor, which can be their own family physician or a family gynecologist, so that would give better insight and detect early lumps if at all the woman has. And beyond 40 years, a regular mammogram, either a year or once in 2 years in India, I think this can help detect early breast cancer. So it's a 20-30-40 rule. That's a mnemonic which every woman can adopt in her life to detect early breast cancer. So healthy lifestyle and normal lifestyle as far as the reproductive cycles are concerned will prevent breast cancer, and the 20-30-40 rule will help to detect early breast cancer. So I think this is what I would like to give as a concluding message.
Thank you. Thank you, Dr. Krishnakumar and Dr. Jayaprakash. I know we are over time. And I think summarizing to our audience, I think, number one, please start if you are not yet diagnosed or if you have members in your family, please remind them to do self-breast exam every month. And if you don't know how to, you can download from our website. We have, cards which you can print and keep for yourself, or there are enough videos, as Dr. Krishnakumar said, on the internet as well, or even on social media sites like Instagram. I think also to the patients, there are solutions. So be informed and have proper discussions with your treating physician. Do not, it's important to understand and not fear. That's really what we want you to keep in mind. And in terms of side effects or consequences, have conversations with people with lived experience, and they can help you deal with those side effects. And also you can seek psychological counseling. There are now psycho-oncologists who help you as well. So, and as Dr. Jayaprakash said, I think rehabilitation is important. So do not forget, to exercise, to follow the guidelines for supportive care as well for breast cancer, so that you improve your quality of life after you are done with your treatment. So thank you once again, Dr. Jayaprakash and Dr. Krishnakumar, for joining us today on late after your work schedules. So really appreciate that, and this has also been supported by Pfizer. So thanks to Pfizer as well for that.
Thank you, Aparna. Thank you.